Hi, I'm Brian Rini from Vanderbilt-Ingram Cancer Center. I'm here at the GU Oncology Now ASCO roundtable with my friends and colleagues, and I'm going to let them introduce themselves. We're going to talk about frontline kidney cancer and then also talk about refractory kidney cancer incorporating the latest data. Tian?
Hi, everyone. I'm Tian Zhang, an associate professor at UT Southwestern Medical Center. I'm really glad to be here today.
I'm Pedro Barata. I'm also a GU oncologist at University Hospital Sideman Cancer Center, Case Western in Cleveland, Ohio. Also very happy to be here.
And I'm Michael Atkins, a medical oncologist and deputy director of the Georgetown Lombardi Comprehensive Cancer Center in Washington, D.C., and I'm delighted to be here.
Thank you all for coming. Tian, I'll start with you again. So given what you heard at ASCO, these IOTK updates, what do you think of them, and is it going to impact your practice, and how?
Sure. It's great to see that these overall survivals are improving for patients who receive immunotherapy-based combinations. I think you're right, and the hazard ratio is changing where early on, right, it's a model of the bad effects of sunitinib alone for that the poor risk inflammatory disease. But then as we get actual events occurring, then we have a more accurate model of the comparison. And what my takeaway is, back in, you all know better than I, 15 years ago, right, where IMDC criteria initially came out, we were looking at median survivals for these intermediate poor risk groups 2 years, 9 months, right? And these have now been pushed out to 4 or 5 years. And that's really, really encouraging for me to see. So when a patient with kidney cancer walks through the door, we're not, just looking at IL-2 or hospice. We're talking through all of these treatment decisions and possibilities. And that's the opportunity to select the first line therapy. To your point, every patient only gets one first line and one try at first line. And so how do we determine that optimal approach for first line treatment, I think, is the challenge now. And so I love that we have these opportunities available. We have the treatment options available. My challenge in clinic is now, how do I select the right patient for the right treatments?
And unfortunately, the data presented don't really help us. But it sounds like if you were Ipi-Nivo leaning in IOTK and select patients, these data probably don't change your practice that much. I don't want to put words in your mouth.
I don't think so. I use all of the combinations with maybe the exception of axitinib is very low on my list. But the others I pretty much use. If you take a smattering of my patients, they're on all of the combinations as frontline approaches.
Okay. Pedro, what do you think? Think of the data, and does it impact your practice?
Right. So great summary, by the way. I'm thinking, I agree. I'm thinking perhaps I'll highlight 2 or 3 other points that we've been seeing as well. I think this data in general kind of reassuring for IOTKI users. In a sense that you started getting numbers, the median absolute number, the patients were all different in all these trials, right? But we're starting, to your point, Ian, about medians OS, right? We're starting in the 50-month range and higher, right? For Clear, I believe, was 53, 54. We're seeing the same with Cabo-Nivo, close to 50. I think the median on Checkmate 214 with Ipi-Nivo is around 47, 48 months. So definitely we've come a long way. The other thing we are seeing is the association between depth of response and outcomes, right? And we have that breakdown. Depends on how we define that. Do we want to group or lump together CRs and near CRs with the PRs at 70% versus 50%? But no matter how we do it, that gives perhaps some arguments to folks who are IOTKI users that, boy, I'm looking after more response rate because that can predict longer, better outcomes in the future. Another way to look at that, as to your point, is what happens to patients who are able to get to 3-year mark, completing IO without progression. Obviously, we're selecting up to probably a third, between a fourth to a fourth of the patients. We saw that in Clear. We saw that in non-ER. We're seeing that now, and those are destined to do very, very well in the long term. And finally, when we look at this is a heterogeneous group of patients. We have the poor, the intermediate, and good risk, which, by the way, we're not quite sure how good that classification is today, but we still use it because it's the best we have. But this is still not enough follow-up for the good risk population, for instance. Whatever we do, they're going to do well. And so that's perhaps one of the explanations where, when we see the curves, no delta there, no big difference. Well, part of that is we're looking for follow-ups of 40, 45, 5 years follow-up. We need longer to actually assess a proper difference. So at the end, I think coming out of ASCO, looking at all these data, I think people who think that the only way to offer cure whatever that might mean to us, is with an IO approach. I think we'll continue to do that. But I really think these data will support the use of IO-TKI in all those cases. That might be 10% for you, and for me it might be 30 or 40 or 50% of the times. It might be even more for the IO-TKI users out there in the community. I really think the data confirms that what we're doing is the right thing.
So it doesn't sound like the data will change your practice that much, because you use the word confirm, kind of confirming those benefits, and I think I also heard you say it's not necessarily going to change sort of a community oncologist who sees 3 or 4 patients a year or 5 patients a year. You don't think these data will turn them into IO-TKI users or turn them into ipi-nivo users?
So that's a great question, because I can answer that in many different ways. When I mean confirm is when we look at how are IO-based approaches, or what is the landscape right now and what is people doing out there. We know there's about 1 or 4 patients getting ipi-nivo today, at least in the US. That means the rest of them, about 20 to 30% are getting TKI monotherapy, and the rest are getting an IO-TKI. So what I mean by that is IO-TKIs are being more utilized today than the alternatives. I do believe these data will get some folks out there to start using IO-TKI in the good risk population, for example, and using a little bit less so of TKI monotherapy, for instance. Others would say, well, I feel comfortable because the median OS for TKI monotherapy in the control group, sunitinib, for example, actually doesn't look that bad, and I'm going to wait for longer data on that. So I mean, that's what I mean by reassuring. And so I think the data is aligned with what people are doing, and I don't predict major changes in their practice. Now, last answer is, what do I think people are doing out there when they're seeing 5 patients a year? I don't think they're trying one IO-based approach, a different one every single time. I think what they're doing is they get comfortable with one of them, maybe 2, and they're going to use it more and more to get comfortable managing toxicity, which we'll talk perhaps today, and understand what to expect from that combo, whatever that preferred combo would be.
Okay, fair. Michael, I'm guessing you have some strong opinions.
Yeah, so I tend to disagree with you. The IO-TKI regimens were compared to sunitinib, and by the overall survival curves as you went further out converged. The overall survival hazard ratios, the 95% confidence intervals around each of those were 0.99 at the top, so just barely significant. And keep in mind, we're comparing to sunitinib, not a pure immune therapy. And if you look at the tails of those curves, for the IO-TKI arms, they're in the 18 to 20% range for PFS, which is below the 30% tail of the curves at 5 years for nivo-ipi. And so they're not producing durable benefit. If you actually look at the response durations, they're under 50% in terms of durable responses, while nivo-ipi has still 60% of patients responding at 5 years, 85% of patients who are complete responders at 5 years. Even with pembrolizumab at for complete responders or near complete responders, there's a median duration of response. Many of those patients are progressing. And so
Can I interrupt you for 1 second?
Sure.
So do you think that lack or not lack of durable response, but the more limited durable response, and I totally agree with you, is it stopping the IO at 2 years? Is it just lack of IPI up front, or both?
I think it's a mistake to think that stopping the anti-PD-1 is the reason. I think there's a sort of misunderstanding about the way immunotherapy works. And it works by producing a potent immune response early, and that potent immune response can eliminate resistant cells if it's potent enough. And by the time you get to 6 months or a year, I don't think it makes much difference anymore. And I think as we get to the second line discussion, I think we'll see data to support that. So I don't think that continuing the anti-PD-1 would have changed things. I view what happened after 2 years in the KEYNOTE-426 study as just what happens if you're getting a TKI over time, those patients progress, and the shape of that curve looks like a TKI curve. The shape of the IO-TKI curves look like TKI curves just pushed over to the right. So in summary, I think immune therapy needs to be given first because it works better in the front line than it works in the second line. It produces durable responses and treatment-free survival responses that persist after treatment stops. And as we'll get to when we talk about in the second line therapies, it doesn't negatively impact the ability to respond to a TKI in the second line. And so except for patients where you think you're only going to get one shot at treating them, why not give them a shot of what looks like a functional cure at least?